morning. Hi, I'm Annette Müller, I'm a PGY4, and I will talk about the exciting topic of quality and service scores today, part of our administration and policy conference series. There we go. First of all, thank you. Thank you to the admin and policy team, Dr. Smeta, Brewster, Dylan, Sheen. Also, thank you so much to Dr. Sweeney and Dr. Pai for sending me a lot of papers. And thank you for Dr. Willis for assisting with my alumni survey. And also thank you to 31 online participants. We are going to talk about quality and service scores, what they are. We're going to look at the common scoring systems, and then we're going to take a closer look at patient satisfaction. What is a quality and service score? I looked outside healthcare first, and I found airlines. So basically, there's functionality. How well do experiences need the customer need? So can the airline take the customer from A to B without crashing? Then there's also accessibility. How easy is it for the customer to do what they want to do? So purchasing tickets, finding the flight they're looking for. And then 3, there's emotion. How did the customers feel about the experience? Basically, in today's market, 1 and 2 are baseline, but 3 is a differentiator for airlines. And who comes to mind? Who is great? Southwest. Southwest's motto is the mission of Southwest Airlines is dedication to the highest quality of customer service delivered with a sense of warmth, friendliness, individual pride, and confidence. Now let's switch to health. How does that look like in healthcare? You know, many people work in healthcare. Think a little bit of this. I found a definition that I would like to share: consistently delighting the patient by providing efficacious, effective, efficient healthcare services according to the latest clinical guidelines and standards which meet the patient's needs and satisfy providers. This is quite complex. So to start unpacking this definition a little bit, let's look at the types of healthcare quality measures. There are structural, process, and outcome measures. Structural measures basically give a picture of the healthcare provider's capacity, systems, and processes to provide high quality healthcare. An example would be, does the healthcare organization use medical records? They use patient order entry systems, or also the ratio of provider patients. Then process measures following generally accepted recommendations for clinical practice. The process measures actually are the majority of healthcare quality measures that are used for clinical reporting. Examples are the percentage of people receiving preventive services like hospitalizations, the percentage of people with diabetes who had their blood sugar tested. The third category is the outcome measure. The outcome measure reflects the impact of the healthcare service of the health status of the patient. It seems like to represent the gold standard in measuring quality, but the outcome is a result of a lot of different factors and often beyond healthcare providers. Example would be surgical mortality rates or rates of hospital-acquired infections. There are also different data sources for healthcare quality measures. There's administrative data, that's like, for example, type of service, number of units, days of service, diagnosis and procedure codes, amount billed. First, the advantage of the administrative data is it's electronically available, it's easy to obtain, it's fairly uniform and fair. Challenges is it has very limited clinical information. Then there's also the patient medical record. Advantage, it's rich in clinical detail and generally regarded as reliable by providers. The challenge is the cost in using the medical record, also the complexity, the time required to pilot, particularly difficult if there are different record formats that are being used and are combined. Then we have patient service. Patient service captures self-reported information from patients about their healthcare experiences. The advantage advantage is that it captures the information directly from the patients. It's also often based on well-established methods for survey design and administration. The challenge is that it's quite costly, and there are several problems in survey design and administration, including, for example, sampling bias and response bias. And finally, there are comments from individual patients. That's more anecdotal information that gets gathered informally. It's becoming increasingly common. Websites make it possible for patients to document their experience. The advantage is it's very relatable for the patient. Patients get direct experiences shared with them, and it's similar to other service industries where restaurants, hairstylists share their grades. One example would be okay. Patients prefer generally the anecdotal information because it seems easier to identify, it's easy to process. It's often emotional, and healthcare decisions are very emotional for most people. And also, it feels a little bit like your family and your friends are helping you figure out where to go. Now, I took a look at one example, and probably everyone knows HealthPace. So I looked into emergency medicine, and I found 4 popping up on the first page. There was this one gentleman in the red circle who had 3 stars. So I thought that's probably mediocre to bad. So I wanted to look why he got 3 stars. So I looked, and there were actually only 2 ratings in there. One of them was a 5, one of them was a 1. There were no comments. So this gentleman is a physician who worked in a New York City emergency department for decades. He's 64, and this is basically the presentation. Now, what is actually a good view of healthcare quality? I want to introduce you to the most commonly used framework. It's developed by the Institute of Medicine. It shows you 6 domains of health: safe, effective, patient-centered, timely, efficient, and equitable. So safe, basically avoiding harm to patients; effective, providing services based on scientific knowledge; avoid underuse, overuse, and misuse; patient-centered, providing care that is respectful and responsive to individual patient preferences, needs, and values; timely, reducing waits and sometimes harmful delays; and efficient, avoiding waste, for example, supplies, also ideas. Then equitable, providing care that does not differ in quality because of personal characteristics. What would be examples for safe? Safe, for example, is there screening, risk assessment, and plan of care to prevent future falls in older people? Or is there avoidance of antibiotic treatment in conditions that don't require antibiotics? What would be efficient? The percentage of patients that are receiving the recommended treatment for various conditions, including most common conditions. Then patient-centered would be education and patients. Also here, the patients reports on care and service they receive from the physician. And timely, the percentage of patients who receive certain medications in a certain time, for example, antibiotics, or also the patient's reports on the timeliness of care and service they receive. Efficiency is, for example, appropriate use of imaging studies, and equitability is comparison of the care that is given across gender, ethnicity, geographic location, and socioeconomic status. Quality of care measures in general the support of patients' choice, and it influences patients' decisions. It requires a high degree of data validity and reliability, and there are complex requirements for the data collection, including survey design, standardized definitions, and procedures. Patients would really like to see information about physician quality, but in general, there are a lot of challenges when you think about physician quality scores, and there's very limited. There's 2 big buckets. There are political challenges, for example, the consensus of physician stakeholders, but also the consensus of which metrics would be appropriate to publish. Then secondly, there are technical challenges, often very small patient populations, the data sources are expensive, and the information systems are standardized. Some specific issues, for example, measuring individuals versus group practices. Often the individual has a very small N, and then often it happens that not nutrition is measured, but for example, the and the individual performance somehow is lost. Another issue is the attribution of patients to the physician. So who actually receives the score? The patient gets treated by various physicians. That could be the physician who's most visits by the patient, could be the physician that basically is chosen by the insurance for the patient, could be the physician who produces the highest healthcare related costs for the patient. In the ED, that's specifically who gets this, the resident or the attendant. And what happens if you do a sign-up? In the ED, also only the discharged patients contribute to the score, not the sick patients, not the patients that are transferred, and those are generally patients the physician spends. I'm going to talk about a little bit of history. Press scanning. In 1985, two professors, Irvin Press, medical anthropologist, and Rod Ganney, a sociologist and statistician, started press scanning. That's where the name comes from. And they basically created a new market for inpatient satisfaction scores. Over the next few years, more players entered that market, and it expanded to emergency, outpatient, ambulatory surgery, medical, and other consulting companies entered the market to provide consulting services. How to In 2002, the Centers for Medicare and Medicaid Services, from now on called CMS, and the Agency for Healthcare Research and Quality, AHRQ, developed the so-called HCAHPS, the Hospital Consumer Assessment of Healthcare Providers and Systems. The HCAHPS was approved in 2005 by the National Quality Forum, implemented by CMS in October 2006. In 2007, we had the Deficit Reduction Act, and hospitals started receiving financial incentives participating in HCAHPS, and the participation at that point increased to up to 95%. In 2008, there was first public reporting of HCAHPS, and that was still voluntary reporting by the hospital. In 2010, we had the Affordable Care Act, and the financial incentives were strengthened, and Medicare reimbursements were linked to HCAHPS performance. In 2015, Press Scanning integrated the HCAHPS in their survey and added their own patient-centered questions. Today, hospitals that are paid under the IPPS, Inpatient Prospective Payment System, are basically rated according to the survey. And if you fail to submit sufficient numbers of surveys and if you perform poorly on the survey, you can have a payment reduction by 25%. Today, also, for most senior health executives, pay is linked to patient satisfaction scores, and as said, hospital reimbursement is directly. So we did an alumni survey, and I asked our alumni which quality and service scores they were aware of. And then I asked them to tell me what they found positive about them, what they found negative about them, and generally to share a few of their stories. So first of all, which scores they were aware of. So you see that there's a wide majority who's aware of Press Scanning, and next is HCAHPS, which is, as we know now, is kind of combined. Then there's a Joint Commission for Measures, and there's Leapfrog, there's HealthBridge, which we talked about before, Kaiser Permanente, Kaiser employees mentioned this, and then there's. Let's quickly talk about the top scoring tools here and companies. I'm sorry in advance, the next page is a little bit busy. Press Scanning first. Press Scanning works with 26,000 facilities, that's 60% of hospitals in the US, and their mission is to help reduce patient suffering and improve quality, safety, and experience. They administer, analyze, and publish the HCAHPS survey with additional questions added. A minimum of 30 survey questions are generally required for them to do statistical analysis, but in fact, even if it's a smaller number, they still do some analysis and publish it. In the ED, a patient can only receive the survey every 90 days, and the survey excludes admitted patients and patients who are transferred, and left without being seen is also excluded. PET scanning also administers several other surveys, and they provide consulting service how to better scores. This is an example for the PET scanning. So I thought it was interesting. You start out here, admission, you have the room, you have the pleasantness of the room, you have the room cleanliness, you have room temperature, you have the noise level in and around. Then you go right to the food, you see the temperature of the food. Important for us, particularly, is here the physician section, where we ask about the time of physician's interview, the concerns, questions you were asked, if the physician kept you informed, the friendliness and courtesy, and finally, also the skill of the physician. And in the end, when you come to the overall section, I thought it was interesting that there's like an overall cheerfulness of the hospital. That is awesome. Just a quick snapshot. The next scoring measure that we talked about is HCAHPS. It was the first standardized and publicly reported survey to measure the patient's perspective nationwide. You can administer it per mail in multiple languages, per phone in English and Spanish. You can also do mail with phone follow-up, and you have some interactive voice response. The survey can be taken within 48 hours to 6 weeks after discharge, and patients can only be surveyed once a year. An eligible patient must be at least 18 years. The primary diagnosis cannot be psychiatric. The patient has to have stayed at least one full night and must be alive at discharge. It is not assigned for pediatric patients who have a primary behavioral health diagnosis. And they also say patients who did not stay overnight are also excluded because they have not had enough interaction with the hospital staff considered in the overall survey. Patients must be accessible after discharge, so that means patients with a home address outside the US are excluded. Patients with no home address are excluded. Discharge to hospice care or specialized care facilities like nursing facilities are excluded, and prisoners are excluded. These are the buckets of questions HCAHPS asks. And generally, it feels like it's not that applicable to the emergency room. So one thing that happened was in 2012, CMS developed the ED. That was designed specifically for adult patients, hospital-based EDs who were discharged home. It's 35 questions. They focus strongly on communication, coordination, arrival, care during the discharge, and some demographics. The use of the ED cuts is completely wrong. And it has very complex ways of administrating it. Everything is combined per mail with telephone, per survey with telephone, per web-based with mail, and then telephone. This is an example for the ED cuts. You see that when you arrive, why did you come here? Did you take an ambulance? How quickly were you seen? Then during the emergency room visit, a lot of questions about, did you get medications? Did you know what they were for? Did you talk to side effects? Did you get imaging? Were you told why you got that imaging? This is important for us, 14 to 16. During this visit, how often did doctors treat you with courtesy and respect? And you see it's never, sometimes, usually, and always. Also, did the doctor listen carefully to you? And did the doctor explain things to you? Then, upon leaving, questions about follow-ups and prescriptions. People talk to you, people explain to you what was supposed to happen. And in the end, the overall satisfaction rating, would you recommend us to your friends and family? The next tool is the Joint Commission core measure. Sorry, I moved up a little bit. The core measures are national standards of care and treatment processes for patients. And basically, it shows how often a hospital actually provided treatment according to those guidelines. In regards to the emergency room, the metrics are basically limited to the time patients stay in the emergency department. And what I found is reducing the time in the ED improves access to care specific to the patient's condition. So we basically only track how quickly to get the patient out of it. So the two metrics that we have here is admit decision time to ED departure time for admitted patients and the median time from ED arrival to ED departure. And just a quick glimpse on the fourth most well-known, the Leapfrog. The Leapfrog surveys is a nonprofit watchdog around for 2 decades. Mission is to serve as a voice for healthcare consumers and purchasers. And it does, for example, the hospital survey. It also does the hospital safety grade. You see it here, it's a letter-based grade from A to F. And hospitals submit the hospital survey voluntarily. And they're given letter grades, but those letter grades are given if you submit the survey or not. If there's any other data available about the hospital, the letter grade is based on that. So that's an incentive to actually complete the survey. Now, let's talk a little bit about what our alumni think about the surveys. There were quite a few pro comments, and I grouped them in categories. So one was it increases physician self-awareness. It helps to open your eyes to how empathetic you are. Someone said it helps you identify things you can improve on as a physician, and it also gives you feedback on how well you're doing explaining care to your patients. The next one was you can identify and address behavioral issues. And I'm quoting, I think it helps identify individuals on either end of the spectrum who need help with their patient interactions or who can serve as role models or teachers in an organization to improve the department as a whole. Someone else wrote maybe a few sociopathic doctors. Then we have identify systemic issues. So it raises awareness, quality issues. It also puts some weight on those issues when they show up in the survey, and some respondents wrote that actual improvements were made in response to this. Also system improvement, standardization. I read that efforts to reach an agreed upon best practice and generally to standardize and use variations of practice. And finally, to see the patient perspective directly. 4 people thought they were absolutely pros. Let's talk about the negative aspects. There was quite a bit of concern about negative impact on clinical behavior. And what people said was doing what the patient wants and doing what's right aren't always the same. And we're rewarded for doing what the patient requests. It could encourage the physician to do things that are not medically necessary, but is the supposed. So common concerns were prescribing antibiotics or imaging. That is something that's indicated. There were various studies out there, and several studies showed that there is, for example, no increase in antibiotic prescriptions. And most of the studies had very small n's, and Dr. Simpson liked them. And then also we heard that these metrics can actually encourage poor care. There was a larger study that correlated improved scores with reduced visits to the ED, but increased inpatient stays, increased overall healthcare expense, increased prescription drug use, and even increased mortality. There are other studies following this first study that basically say higher scores don't increase your mortality. It's probably more related to the fact that if you're sicker, then you have a different relationship to your physician. But there are lots of studies out there that look at both directions. It's pretty controversial. Also, the next was the surveys are sometimes quite detached from clinical reality, focus only on the numbers. And for example, one person mentioned did the doctor give you privacy question? Pretty useless. There's also a study that compares different settings. The same group of physicians practiced in 2 different settings, And what they found was that the scores physicians received varied significantly. One of them was more an urgent care setting, and the other one was more in the urgent care setting, which also had higher resources. The scores were much higher. In the ED, the scores were much lower. Could be, again, related to the fact that in the ED, the people who probably provide their feedback are the ones that are being discharged, the sicker ones that are being admitted, transferred. So those people might have been better off going to urgent care, but they went to the ED and had to wait and had to endure all the other negative factors. Then people mentioned that the scores can undermine physician confidence. Someone wrote fear of getting a bad review, unhappy staff. Someone said sometimes clinical brilliance does not correlate with being nice. And someone else wrote the pressure to get higher scores and frustration with frivolous, unproductive things can be source of frustration, dissatisfaction, and poor work environment. Even said these scores have done as much harm to medicine as litigation. There's also a concern about poor data quality. You don't really know who provides the answers. Could it be the patient? Could it be relative of the patient? And people were concerned about possibly poor survey design. Another concern was the low response rate. There was an answer to this concern from Press Ganey directly, and they looked in other service industries and said basically in healthcare, response rate is 30%, which is higher than in other service industries. But looking at the individual physician, sometimes the ends are still very, very small. One person actually wrote that he got a long report that detailed all his feedback to the patient, and then at the end of the page, there was an N of 1. Then it could be a focus on unhappy patients. People are concerned that people who have a bad experience are more likely to fill in the survey. HCAHPS was analyzed in that regard, and Press Ganey actually published that comments were evenly distributed about the low, medium, and high ratings. But this concern is still very consistent between our respondents. Then it's also out of physicians' control. Which patients are attributed to you? We saw the questions. How much of that can you actually influence? And the concern was you might be recommended things that are out of a big concern that has also come up is racial and gender bias. And there are multiple studies out there that show, for once, that female physicians are generally scored lower than physicians, and also physicians of color are generally lower than white physicians. So one study says that female physicians have only about 46% chance of getting the same scores as their counterparts. And there are a lot of other studies ongoing trying to show this racial bias in the consumer satisfaction surveys. There were also two people who thought there were no negative sides to the survey. So basically, who do you want to be as a physician? Do you want to be like Spirit and your patient is happy they get through and they survive at the end? Or do you want to be like Southwest and the patient is delighted? There was actually one article that explained the benefits of music therapy. So think about it, if you have a talent, singing, instrument. A little bit more seriously, thank you to Angela. She provided this. This is an MRAT cheat sheet. How can you get a perfect patient satisfaction? So how do you introduce yourself? Do you stand or sit? Do you shake hands? Not right now, but maybe elbow bump. Do you keep eye contact? The initial interview, do you spend the time? Do you answer the questions? Do you appear rushed or not? Then continuation of care. Do you check in on your patients? Do you keep updated? In the conclusion and transition, do you explain things to them? Do you explain and follow up with prescriptions? And in the end, you feel extra generous. You could even ask, how did we do today? Are there any issues that need addressed? Another thing that research suggested would be helpful, because we're talking a lot about service and much less about quality. Provide the patients with a framework to understand healthcare quality to help them submit their scores in a more appropriate way. And maybe weigh the quality of the clinical care that was provided higher than the temperature. And finally, here you see Maya Angelou, who says, So it is generally very much about people, the doctors, the nurses, all ancillary staff. How do we interact with patients? We make value understood. Do we explain to them why delays happen? Keep that in mind, please. Right. Almost at the end. Any questions, comments, concerns?
So those scores that you showed initially, those scores will be the scores that also the physician will get, like the ones about the hospital's cleanliness of food and nursing, or is it that they separate the physician directed questions too?
Okay, so the question was what kind of responses physicians get? They get the responses. So from what I understand from the responses, physicians mostly get their own scores and their own feedback, but there's a concern that, for example, if the other scores are ranking poorly, that also impacts physicians.
Okay.
Any more comments, Dr. Willis?
Just a comment. I mean, I think you did a great job presenting it. I think just highlight this is very important. A lot of places you pay work. Sure. Your salary, your job will be tied into these scores. Other hospitals take it very seriously. And then could you send out that like cheat sheet to all the residents? I think that would just be helpful, getting an idea of what is looked at. And I think we should be practicing this anyway, even if it's not until you're getting that feedback. And it's good practice for when you are potentially setting.
There was actually one comment from one of our alumni who said pay is often linked to those scores, and the advice was don't ever work in a place that does that.
Yeah, but bonuses are linked to this stuff in a lot of practice.
Yeah. Any more comments, thoughts? Yes.
Just want to let you know that a lot of places they do coach you and how to get a higher score. And it was shown, for example, when you arrive out to discharge patient, use certain phrases, for example, did you address all your concerns? But it's the exact question which will be on the survey. If you use it, then people tend to remember that question. They're going to get higher. So basically, there's a way to increase it up to a certain point if you're appropriately coached. And again, in places where the money are really directly tied to that, people take it very seriously, not just to look at your scores, but also they spend some time with coaching you, and it's not all of it, it's about what you deliver here, it's how you deliver it, and if you ask appropriate questions, you can kind of, I hate to use the word, cheat the system, but yeah, certainly you can bring those numbers up without really spending much resources on improving like the area of care, increasing the number, just by asking those at the end of the discharge. If you ask those questions, you increase your score in the whole hospital visit score without actually investing in your.
Thank you. Any more comments or questions?
Right. Thanks, Annette.